recently, since past 4 months, I have joined a Nirali Cancer Institute. Since that day, the work has increased. I do get on and off reference for the oncology, especially the axis, which is the topic for today. So, but so I have observed recently that I do get reference for axis, but the many of them are not in an operable stage. They are beyond the IR treatment. So,
So
what
that's
can we?
the problem that we all face, Jenny. And I think one of the things that we have to encourage people is to start screening high-risk population. And as we know, that cirrhosis is that one condition that predisposes to hepatocellular carcinoma. I'm sure in your practice also, Jenny, that's something you saw. The vast majority of your patients are hepatocellular carcinoma secondary to cirrhosis, isn't it?
Yes,
But
that's true.
that group of patients should get screened, and I think they should have at least an ultrasound done once a year and an alpha fetoprotein done once a year. And I think that may probably change this picture because I do not think we can get patients without cirrhosis because that itself is a contraindication for surgery. So I think we should encourage a lot of people to start screening people with cirrhosis, both with tumor marker and ultrasound. What do you think about it, Jenny?
Yes, that's true, sir. That we see this HCC beyond certain age. So, in a high risk population, we should definitely screen them with ultrasound and AFP. So, suppose if there is a suspicious lesion on ultrasound, then how do you investigate it further?
So if the alpha fetoprotein is high, suppose it's more than 500, you don't need anything else. You don't even need a biopsy because it's considered to be a confirmed hepatocellular carcinoma. Now, suppose you have a lesion, suspicious of whatever size, and if the alpha fetoprotein is not high, then both MR with contrast or CD with contrast itself is a confirmatory test. And I know, Jenny, you know that too. So because if we have
Yes.
early enhancement and a washout, which is like a signature for hepatocellular carcinoma, that itself is enough. So I think that in a patient, either with a raised alpha fetoprotein or a suspicious lesion, the next investigation should be a cross-sectional imaging, and biopsy being only reserved when both these modalities show a pathology, but at the same time they don't have a signature that is typical of a hepatocellular carcinoma. I think that's the way we should go ahead.
Okay. So, sir, suppose on cross section and how, like you said, if XCC is confirmed, then how do you proceed further for the intervention?
Right. So, the interventional procedures today for hepatocellular carcinoma basically is two. One is an ablative therapy, either microwave or RF, or the other one is using an intra-arterial route. So the first thing, when would you choose an ablative therapy? So today we know with radiofrequency ablation, a lesion which is less than 3 centimeter works perfectly fine. Even if there are multiple lesions, maybe up to a maximum of 3, with microwave, we can even go up to 5. There are some relative contraindication if it's close to the hepatic vein or portal vein. And we know that with microwave, those contraindications also are much lower. Once it crosses this magic number of 5, then we have to think of giving an intrathecal therapy, either in the form of conventional TACE or a drug-eluting bead or a radioactive treatment in the form of tear, with yttrium beads. So those are the kind of spectrum of treatment. Of course, when it comes to surgery, Jenny, you are aware of the fact that we can allow one lobe to hypertrophy by completely embolize the portal vein. But I think what you're talking about is more to do with therapies which are directed directly for the tumor, right? So what
Yes.
exactly is your common form of treatment? I mean, are you using conventional TACE or do you use
Yes,
drug-eluting?
I still prefer conventional taste. The reason being one is the cost. So I prefer conventional taste. What's your preference, sir?
So having said that, I think in a lesion with a very normal liver function, we can probably still do conventional TACE. So you know the key difference. In conventional TACE, we actually mix lipidol and we mix the anti-cancer drug, which is doxorubicin, and we inject this emulsion. So invariably, the drug goes to the peripheral circulation. So the patient has a lot more toxic effects. We see more nausea, vomiting, fatigue. We also see a much larger rise in liver enzymes. But on the other hand, if a patient can afford drug-eluting beads, it's a much better agent according to me. One, the drug is impregnated into the bead, and we know the drug elutes for 14 days. So most of this drug goes directly to the tumor, and the contact time is much longer. So because of that, I think it's a better choice, at least in terms of patient comfort. If I would take a scientific study and data, maybe the results may not vary too much, but I see a patient doing better clinically in terms of no nausea, no vomiting. We can discharge them 24 hours later. So given a chance, I would prefer drug-eluting beads. But I agree with you, if a patient can't afford it, please give conventional taste. It's better that they have that than not having anything. And we have had patients who live for 4 or 5 years with conventional taste. So I totally agree with you. I think we have to, in India at least, we have to tailor it based on the need of the patient.
But so there is a special condition like when there is a HCC with rupture or there is a portal vein thrombosis, then the conventional TACE is not the option. Then how do you will you prefer
Yeah.
DEB or TAE?
That's a fantastic question. Actually, what you asked me is something I think is not even described in a textbook. So I think I'll tell you from our own experience how we handle the ruptured HCC. Now you worked with us and you remember we used to use dilute cyanoacrylate glue. And we
Yes.
found that that was fantastic. Not only does it kill the tumor, but we never had a second rebleed with that. But if you want to go by a total textbook description, I think drug-eluting beads are better because they block the vessel and they elute. So if it's a small lesion, I would still strongly recommend dilute glue. If it's a larger lesion, if you can see the point of rupture, I would still suggest go there, inject some glue, and the rest of the area use drug-eluting beads. The other question that you asked is totally different. I have a patient who's got a portal vein thrombosis, and how do I treat? Now, in a center like mine, I have an option. I can give them yttrium beads because I got a full-fledged nuclear medicine department that is licensed to use yttrium. So there is an advantage. We know that it does work. We have studies to show it does improve the quantity and the quality of life. But having said that, it's an exceptionally or a terribly expensive procedure. First sitting will cost about 12 lakhs. The drug itself is about 6 lakhs. The first preparation of the patient will cost 2 lakhs. Then we got a nuclear medicine study to be done. Not many people can afford this, especially when you tell them, this is going to prolong your life, not cure it. So there's another thing that we have been doing, Jenny, and which you can actually try even in Surat in your hospital. That is, you do conventional taste and send the patient for focused radiotherapy. And they
Okay.
will work just on the portal vein. And believe me, it also produces good results. So that's an
Okay.
option. So don't let go of these patients. Don't say there's nothing I can offer. Try it out and you'll be surprised. The results is pretty good. And also, of course, that pretty decent chemotherapy coming today with targeted therapy, and they also show good results. So I think we have to combine modalities when you have to treat these difficult lesions, especially when you have got the main tumor and the portal vein going. Does that answer your question? No.
Yes, sir. So one more, can you just brief us with the techniques of conventional taste, DB, and the TAE?
Okay.
Like
So,
how to prepare?
yeah, okay. Now, in all the patients, one key thing is make sure your patient is well hydrated because all these patients will end up in having tumor lysis. If the patient is a candidate where you're going to use doxorubicin, it's a good idea to take the cardiac evaluation because we know it's cardiotoxic. If you're going to use cisplatin, have a good look at the renal function because they're nephrotoxic. So after that, today we will do a CT and a CT angio to mark the vessels, and then we take a catheter into the main hepatic artery, and after that, a microcatheter. Actually, you know that the preferred microcatheter I tend to use all the time is ProGrade because I've been using it for a long time. And then whether we use lipidiol or whether we use the drug-eluting beads, the technique is the same. You go and embolize it and ensure that you go to the target and don't use too much of normal tissue. But I will talk about yttrium after you are okay with what I've told, because if you have any doubts at this point, you can ask me now, because yttrium, the whole thing is totally different. So is there anything else you want to know? Like we mix it, using two syringes, and that you
Yes.
know it because you have been doing it yourself.
So that's about conventional taste. What about the drug-eluting beads? How
The
to
drug
prepare it?
is very similar, except in injection, except you prepare it. So you get these beads. Hepaspheres comes dehydrated, and DC or drug-eluting beads, which is called the DC beads, they come wet. So if it is drug-eluting bead DC beads, we aspirate the superlatent, and you are left behind with just the blue color beads. So we take doxorubicin, which has been mixed with the solvent that is given to you, and we leave it inside the vial for at least 1 hour. Then we aspirate the superlatent fluid, take only the beads, mix it with contrast, and then we inject it. With hepasphere, it's a little different. We first put the doxorubicin, then aspirate it into a large syringe. I do that, it's easier. Then once I've got it to syringe, I keep that syringe upside down and I wait for 1 hour so that a superlateral fluid can be taken out. Then again mix it with about 20 ml of contrast, and then we go target it and we inject. Of course, we have an advantage. We have a on-table CT. So
Yeah,
most
that
people
is
take a
it.
CT, which is very helpful. Obviously, we are sure whether we have covered the target or we have missed something. So that's
Okay.
how we do both of them. And like I said, both of them have good results in good hands.
Okay. So what is your post-treatment protocol like for next 2 days?
Yes. So
Because that will be
technically,
first.
most of this patient will have some abdominal distension, paralysis. So we would keep them nil only at least for the night. Some pain relief may be given. And if the liver function is okay, we would give them basically opioid like methylene and phenergan. If the liver function is deranged, we would be careful with analgesics. We actually try to avoid analgesics. And though they say that paracetamol is hepatotoxic, we still use it in this group alone. And the rest of it is just making sure that the patient doesn't go to hepatic coma. So we would give them lactulose and we give them Rifagut and ensure that they don't have constipation and keep a close monitoring on the electrolytes and the liver function. Sometimes patients have hyperkalemia and metabolic acidosis, especially in large tumors. So we have to give them alkaline diuresis. So every patient will have a potassium done at 24 hours, a total LFT done at 48 hours. And if they are getting deranged, we'll keep the patient back for a couple of days more and treat them as though they're in encephalopathy. So that's the standard of care.
Okay. And so when do you ask patient for the follow-up, the first follow-up?
So when we are using TACE or drug-eluting beads, they come after 4 weeks. But if we are using, say, a radioembolization, we would call them after 8 weeks. So the technique
Okay.
you asked me of radioembolization is very different, as you know that. We first see the tumor, then we do a knock and do an angiogram. We block the gastroduodenal artery. We block the right gastric artery. Then we go into the tumor bed and inject this agent. But before doing that, we have to do an estimation of shunt that takes place to the lungs. That's why it gets expensive. Because after blocking, we do an angiogram, then we put a microcatheter into the tumor, then we send them to nuclear medicine, then they will inject technetium, which is aggregated on albumin, then they will look at what is the shunt, the radioactivity in the lung. Based on that, there is a calculation of the dose. Then we order the drug, which comes either from Australia or Singapore, and then we actually inject. Then we call the patient after 8 weeks. And here the only difference is we have to give them very high dose of ranitidine or a protoporphyrin inhibitor, because any reflux goes to the stomach bed, then you can have a non-healing ulcer. So otherwise, technically,
Okay.
it's same microcatheter there, but we have to block the vessels and do the shunt estimation.
Okay, sir. So, when if we have offered first sitting of TACE or TAIL, then how frequently can we do it on the same patient? Suppose a tumor is somewhere around 8 centimeter. It's not gonna go in one sitting. So how do
So
you
we
proceed in
call
this
the patient
situation?
back after 8 weeks. We look at the residue, and we can definitely treat the patient one more time. It's never a problem. We have also done it even 3 times, but generally, we finish it at two. Also, remember that it's a very expensive treatment, so affordability becomes a problem. But the results are pretty dramatic. The advantage of radioembolization is not just for portal embolization. It works for cholangiocarcinoma. It also works well for secondary deposits. So the spectrum of use is much larger. And we also find the hepatotoxicity is very low. So if you have a patient with a hepatic derangement, even in that group it works well. And patients do well for a couple of years.
Okay. So we'll again come to a question where we started. How to get the patient directly to the IR? Because many times I am not getting the patients. Patients are get diverted to the gastroenterologist and put patient on a sorafenib, and or the patient or family comes and they just don't want to get the treatment done for the cancer patients. They just take patient back to home without any treatment, simple on painkiller or antiemetic drugs or just IV fluids. So I have to convince clinicians to get more patients for the IR.
Yes, so I think it depends on and having an excellent rapport with the general practitioners and with the gastroenterologists. And even I've seen another very large referral base in liver transplant surgeons because one of the treatment options is liver transplant. And when they wait for a donor, they actually would like you to treat it so that the tumor doesn't grow. But I think to a great extent, the general practitioners can do a great job because we want them to get all the cirrhotic patients screened and ensure that they find some abnormality, and they should be also very comfortable with the fact that you're going to send the patient back to him and they can do the follow-up for us. The first month they can come back, then after that, they can repeat a CT at the end of 3 months and 6 months and keep us updated. So I think it's getting the general practitioners and gastroenterologists to know that such an option exists. And I think they should pick up cirrhosis and keep them under surveillance all the time.
Okay. So thank you, sir, for the wonderful uh, talk.
No, no, it's
And
chatting with you. It's good to see you after a long time. And
sir, I have realized one thing, whatever topic we choose, whatever question we ask, you have an immense knowledge of that. Be it IR technique, wire catheter procedures, anything. I think even
that's
if
because
someone
these are
calls you at
very
the middle of the night and you're just awake, then also you can speak for 1 hour.
yeah, but it's because Jenny, you must understand there's a difference between the younger people and us. I started interventional radiology in 1990 when there were no devices. So every device that came into the market was evaluated by us, tested by us, and we started growing with the devices. So the company Termo, I know who is actually sponsoring this. You must know that I know more of their products than they do because I was working with Termo 30 years ago. When they were probably in school, right? So it works that way. So I think it's a lot. You have got say 5 years of experience. I got 30 years. So obviously you know much more than your daughter about the world. I know much more about interventional because it's all about the number of years we have been in this business.
No, sir, but your knowledge is unmatchable.
Cheers to that,
Uh,
sir. And with that, we have got some of the questions. If
yes,
you please.
please
Okay, so
ask us a question.
first one is how do we sequence it along with chemotherapy in your experience?
Yeah. So normally we would actually uh, treat the lesion, but during the treatment we do not combine any additional chemo. Sometimes the toxicity becomes too much. So after we completed the TACE and after we feel that the patient has responded well, we can actually ask also to follow it up with chemo. Sometimes when we find this residual lesion or a recurrence, again we follow it up with chemo. So it would actually work uh, closely when we find the response to transactional therapy is suboptimal. But if you've got a great response and you find sometimes completely burnt out, you do not need any additional chemo.
So one question from my side, how will you calculate a dose of doxorubicin and the amount of lipidol? Suppose if it's in a conventional case.
I didn't get that question. Sorry, what did you say? How do
So
you
how do we calculate the
So
doxorubicin?
technically, we can give up to 150 milligrams of doxorubicin on an adult. So we actually look at the tumor size. We also look at the LFT. So if I got a tumor which is say 5 centimeters, I know 75 milligrams of doxorubicin works fine. But if I've got a patient with a 5 centimeter tumor, but who's bordering on child B, child C, I will reduce to 50 or even 30, because I know that I cannot damage more liver. So it's a combination of both these factors that they look. I can see a question
And
here that asks me, please guide us
Yes.
with the transradial approach. So transradial approach is indeed, if you ask me, doesn't make a big difference unless you're doing a procedure where the patient can go home the same evening or next day, because technically he's lying down and after TACE, after tear or TACE, and then with a 4 French and a 5 French sheath and a catheter, they just lie down for 6 hours. But abroad, it's a very different story. Bed charges are very, very expensive. Now, if a patient stays 2 days extra in the hospital, the bill is going to be 3 times more. So their transnatal is used because he does a tear and he discharges the patient after 3 hours. So if you ask me, I am not so bothered about it really, except the patient comfort that for 6 hours he doesn't have to lie down. But it's good. I mean, we do transradial. Today I was doing a morning, I did a transradial procedure for somebody with a stroke. But to me, if you ask me in an Indian context, when a person doesn't have money to eat bread, need not offer them cake because the procedure is more expensive. The devices cost more. So I honestly am not so bothered which route you take as long as you get the patients and you give them treatment. But definitely, it's a little more comfortable on the patient.
okay.
Okay. And we have one. How to do tastes in patients with emphasis feeders from proper hepatic artery, especially in caudate lobe lesions?
Yeah, so that's again a great question. So they are one of the most tricky lesions. We still try to go super selectively into the small vessels and treat them. But but having said, but, I've been doing TACE for 25 years. Usually there are not many vessels. Even when they come, it will be 1 or 2 vessels, and some will enter with a microcatheter and wedge it. Without that, it's technically challenging because even I put a balloon and it deflated, the material will fly. So I would still go as much as I can and try to do it. That's the approach I follow.
And in your experience, percentage are for the treatment and how many are for pre-transplant, and how is your experience for pre-transplant patients?
Kidney transplant? Did you say that? I didn't get it. Your liver transplant or
E-
kidney? Your voice
Yeah,
is cut
yeah,
off.
liver transplant is
Yeah.
pre-transplant.
So we do get patients who are waiting for a transplant. If they don't have a relative donating the kidney, they're waiting for a cadaver, they come to us. Not very common, but definitely a couple of them have.
Okay.
So I
Uh, Sir, I have one question.
Yeah, Jenny.
So can we combine RF ablation and TACE in
Yeah,
particular
of course. I mean,
circumstances?
it's a combination we use very often. We do taste and the patient come, there is some edge, there is a small nodule, 2 centimeters or something. We would ask them to, we would also do an RF because we know we'll burn it out completely. So like I said, we should learn to combine modalities. It works out very well. So we had a tumor which was a 7 centimeters. We treated, now we get a 2 centimeter residue. So you converted a lesion that was not for RF into an RF. So you should come. I think it's a great idea and we should use it freely.
Okay.
And here we see one last one. How would you treat an immediate post-TACE or DEB-TACE or tear rupture? And what could you, at the time of the primary procedure, to avoid this? What you could
So
have
that
done?
we cannot avoid it. I mean, honestly speaking, if you start doing large volumes, you can see rupture once in a way. So the key thing is don't panic, do a CT, demonstrate that actually there is active bleeding, or even if you feel difficult about that, just go ahead, do an angio and block more vessels proximally. Then it works. We have lost only one patient. That's because he had a large tumor, 10 centimeters. He bled in the night, and somehow somebody in the ward didn't pick it up in time. Otherwise, we have had a couple of bleeds, and all of them survived. So you can re-embolize them.
Thank you, Dr. Shailin.
So
Dr. Jenny?
yes, tell me.
Yes, questions are done. Dr. Jenny, up to you if you have anything or.
Yeah, sir, one last question. Sir, after, like, suppose we are done with our mixture of unconventional phase, if we are done with our mixture of doxorubicin and lipidol, and the vessels are still, the blood is still flowing, the vessel is not completely blocked, do you use a bland, do you practice a bland embolization with
So
lipidol?
if your dose is over, one of the things, of course, in conventional taste, the problem doesn't exist because you're injecting gel form after that, and you anyway block the vessel. When you're using DC beads, it can be a problem, and it's a good idea to pack it up with gel form straightings and just complete it. Don't let
Okay.
it continue to have flow.
Okay, sir. Sir, have you encountered any case with which after IR there is any infection in liver
So
in the
we
bed
never
of
have infection
embolization?
so far. In large tumors, we do see liquefaction and necrosis,
Okay.
and that I see a lot more with conventional taste. So that's why when I have a tumor which is about 8 centimeters, I try to avoid using conventional taste. And in our group, we will all move into drug-eluting beads because we find that a little less with that.
Okay. Thank you.
So have you done that? So that was a nice evening. We had a chance to virtually see Jenny's new house. And I thought
Thank
so.
you.
Thank you for that. Yeah. And she wanted me to visit there physically, but with this current situation, we're avoiding that. So thank you everybody for
Thank you.
more.
Thank you.
Yeah.
Thank you, Dr. Cherry. Thank you, Dr. Jenny. And, amazing discussion was very insightful. And for all the people who are watching and actively participating, the recording will soon be available on www.terumoindiacellab.com. And we really wish you great rest of the evening. Thank you all for your participation. Thank you, Dr. Cherry, and thank you, Dr. Jenny, again.
Thank you
Good
once
night.
again.
Thank you, sir.
Thank you,
Thank you,
Jenny,
sir.
for some good
Thank you,
chat
sir.
with a virtual fireplace. Thank you.
Thank you, sir.